Imagine spending like tens of thousands of dollars to meticulously repair the hull of a submarine, right? Making sure every single microscopic seal is watertight, only to take it out into the ocean on day one and just intentionally smash the side of it with a sledgehammer.
Oh, wow. I mean, it sounds completely ridiculous when you put it like that.
Right. It sounds absurd.
Yeah.
But medically speaking, when it comes to pelvic surgery, that is essentially what thousands of patients accidentally do to their own bodies in the first few days they get home.
Yeah, it's a shocking visualization, but a remarkably accurate one. We focus so heavily on the surgery itself, the anesthesia, the OR, that immediate recovery, that we treat walking out of the hospital as like the finish line.
When in reality, it's really just the starting gun.
Yeah,
And that is exactly what we are focusing on today.
absolutely.
So welcome to this custom-tailored deep dive, designed specifically for you. If you are preparing for surgery to correct stress urinary incontinence, SUI, or to repair a pelvic organ prolapse, our mission today is highly specific and, honestly, incredibly practical.
It's all about how you prepare your physical home and, well, your daily routines for optimal healing.
Exactly. Because the moment you walk through your front door,
Yeah.
the responsibility for protecting that delicate medical repair just completely shifts to you. You are suddenly the guardian of this surgical site.
Right. And to help you build what you're calling this ultimate low-strain, high-healing blueprint, we've pulled together a massive stack of post-operative medical guidelines.
Yeah, we are synthesizing protocols from everywhere. The Royal Women's Hospital, Brigham and Women's, Kaiser Permanente, a bunch of specialized urogynecology clinics, and the Association for Pelvic Organ Prolapse Support.
And looking across all these documents, a very clear shared narrative emerges. It really doesn't matter if your surgeon is placing a mid-urethral sling, which, you can picture as a tiny surgical hammock for your urethra, or if they're reconstructing the fascia.
The fascia, that's the internal connective tissue holding the organs in place,
Yeah.
right?
Exactly. They are relying on your body's natural healing process to cement their work. The stitches or the mesh, they're just temporary scaffolding.
So the tissues actually have to fuse together to make the repair permanent.
Precisely. And that fusion takes about 6 weeks. If you introduce mechanical strain, like if you pull, stretch, or push down on that area before the biological glue cures, the repair can literally snap.
Or stretch right out of place.
Yeah, and then the surgery fails. Not because the surgeon made a mistake, but because the home environment just wasn't optimized to protect those tissues.
Well, that makes the stakes incredibly clear. We really need to engineer an environment where you expend zero unnecessary energy and create zero accidental pressure.
Zero.
But what really caught my eye in these sources is that this environment doesn't actually begin in your living room. It starts before you even get home.
It starts in the hospital parking lot, actually.
Right, because getting into a passenger vehicle is a classic high-strain movement.
Think about the mechanics of it. You have to step up, balance on one leg, twist your torso, and then drop your entire body weight down into a bucket seat, all while heavily engaging your core muscles just to stabilize yourself.
That sounds like an absolute disaster for a freshly repaired pelvic floor. But the guidelines from the Association for Pelvic Organ Prolapse Support, APOPS for short, suggested a hack for this that I just had to ask you about.
Oh, I know the one.
They tell patients to bring a large plastic garbage bag and just lay it flat on the passenger car seat before getting in.
Yes. It is one of my absolute favorite pieces of practical medical advice.
Wait, really? Because when I read that, I was highly skeptical. I'm just picturing sitting on a literal slip-and slide in a moving car.
Yeah.
Like, how on earth does a garbage bag protect your pelvic floor?
Well, it really just comes down to the simple physics of friction. Car upholstery, especially fabric, it grips your clothing.
Right, it kind of holds you in place.
Right. Exactly. So if you sit down normally, you have to use your core and your lower body to forcibly twist against that friction to get your legs inside the car. But by placing that plastic bag on the seat, you completely eliminate the friction.
Oh, I see. So you back up to the seat, sit straight down, and then the plastic just allows you to effortlessly swivel your hips and legs forward into the car.
Without engaging your core at all, you just bypass that twisting motion that would otherwise pull directly on those highly sensitive, newly repaired surgical tissues.
That is so smart.
And once you're facing forward, you can just pull the bag out from under you, or honestly, just leave it there for the ride home.
That is genuinely brilliant. Okay, so you swiveled into the car, you survived the ride, and you've made it through your front door. I feel like the natural instinct is to immediately climb into your bed.
Oh, absolutely.
But the Kaiser Permanente and Brigham and Women's sources actually hint that your actual bed might be the worst place for you.
It often is, yeah, especially for the first few days. I mean, depending on the height of your bed frame and how soft your mattress is, hauling yourself out of a deep, squishy mattress requires massive abdominal engagement.
Which is exactly what we're trying to avoid.
Exactly. So many patients find that a firm couch or a sturdy recliner serves as a much safer base camp because the firm surface actually gives you something to push off of.
So the more you describe this, it almost feels like we're prepping a space capsule.
A space capsule.
Yeah, like your recovery base camp is the capsule, and everything you need for survival has to be engineered so it's perfectly within reach, so you never have to strain the hull of the ship.
Oh, I love that. The space capsule is a perfect metaphor because every time you stretch across a coffee table for the TV remote or twist your spine to grab a water bottle off a nightstand, you are stretching that abdominal fascia.
And pulling on the pelvic floor.
Right, so to avoid that, the sources recommend setting up what they call a recovery station.
I saw this. You take a TV tray or a small bucket or even a literal metal cake pan, and you just corral your essentials into it.
A cake pan works perfectly.
You pack it with tissues, a spill-proof cup for water, your phone charger, some dry snacks, your pain medications, and you just place that cake pan right next to your hip on the couch.
It's all about engineering out the strain before it ever happens.
But, eventually you do have to stand up, and the Royal Women's Hospital Guide gets incredibly granular, like almost obsessive about exactly how you're supposed to get up from a lying position for the first 6 weeks.
Yes, the log roll.
Right. They outline this technique called the log roll.
It's a total staple of post-operative orthopedic and pelvic care.
They say you have to lie completely flat, bend your knees, roll entirely onto your side, keeping your shoulders and hips perfectly aligned like a log slide your feet over the edge, and then use your arms to push your torso up sideways.
That's the exact sequence, yes.
Is all that multi-step rolling really medically necessary just to sit up? I mean, it sounds like a lot of work.
It absolutely is, and the reason points to the biggest overarching threat to your recovery. Think about how you normally sit up in bed on a Tuesday morning. You basically do a mini crunch.
Yes, you just sit straight up.
Right. You engage your rectus abdominis, those are your front six-pack muscles, and you heave your torso forward. Well, when you do that, you are creating a massive spike in intra-abdominal pressure.
Okay, intra-abdominal
I
pressure.
want you to visualize your abdomen as a sealed cylinder, like a can of pressurized dough.
Okay, can of Joe.
The top of the cylinder is your diaphragm, the sides are your abdominal muscles, and the bottom of the cylinder is your pelvic floor.
So when you crunch forward to sit up, you are essentially squeezing the middle of that sealed cylinder.
Exactly. And the pressure inside that space has to go somewhere. Since the pelvic floor is the lowest point, gravity and the compression shoot all of that internal pressure straight down onto your surgical incisions. Yeah. By doing the log roll instead, you keep the cylinder perfectly neutral. You use your triceps and your shoulder muscles to do the lifting, completely bypassing your core.
Okay, so if simply sitting up in bed creates enough downward force to threaten the repair, what happens when we start adding external weight into the equation?
That is where the guidelines become incredibly strict. The universal consensus across all these post-op manuals is a severe restriction on lifting.
They call it the gallon of milk rule, right?
Yeah.
The sources state you cannot lift anything heavier than 10 to 20 pounds, though I saw many conservative surgeons cap it at just 8 pounds for the first month,
And a full gallon of milk weighs a little over 8 pounds.
making it the absolute maximum safe payload for your body.
Exactly. And that rule completely alters your daily reality in ways you might not anticipate. I mean, you can't carry a heavy cast iron roasting pan out of the oven.
Oh, wow, right.
You can't carry a basket of wet laundry. And this is the most emotionally difficult one for a lot of patients. You cannot pick up a toddler or a small child.
Because if you think back to the biological glue we talked about earlier, putting a 30-pound toddler on a curing pelvic floor is going to shatter the repair.
It really is. And it isn't just heavy lifting that poses a threat either. The Brigham and Women's Hospital discharge instructions explicitly ban almost all forms of normal housework.
Wait, really? All of it?
Pretty much. No vacuuming, no scrubbing floors, no pulling heavy wet clothes out of a front-loading washing machine.
I read that even picking up a dropped sock is a hazard. The guides note that bending over at the waist compresses that abdominal cylinder we just talked about.
Yes, the compression is the enemy.
So if you drop something, you either have to leave it there, sit down in a chair and scoop it up with your foot, or you have to do a perfect straight-backed squat to keep your torso upright.
Which really underscores how entirely unaware we normally are of the physics of our own bodies, you know? We
Yeah.
generate spikes in intra-abdominal pressure constantly throughout the day just by living.
Which brings us to the one daily activity you absolutely cannot avoid, and where intra-abdominal pressure naturally spikes the highest, the bathroom.
Ah, yes. The bathroom is arguably the most dangerous room in the house for a post-operative pelvic floor patient.
The Royal Women's Hospital provided an incredible diagram detailing the optimal posture for using the toilet, and it honestly looks like a very specific ergonomic exercise.
It really is.
First, you need a footstool under your feet, high enough that your knees are actually elevated above your hips. Then, you lean forward, rest your forearms heavily on your thighs, let your stomach completely relax so it bulges outward, and whatever you do, you must not hold your breath.
So from an anatomical perspective, that posture is doing two brilliant things simultaneously. By bringing the knees above the hips, you are relaxing a sling of muscle called the puborectalis.
The puborectalis.
Yeah, that muscle normally wraps around your rectum and keeps it slightly kinked to maintain continence. Elevating the knees unkinks the hose, so to speak, creating a straight exit.
And what about resting your forearms on your thighs?
That takes the weight of your upper body off your core, essentially shutting down the abdominal muscles so they can't contract and create pressure.
Okay, but why the strict warning against holding your breath?
Because holding your breath while bearing down is called a Valsalva maneuver. It acts like a piston, driving extreme force down into the pelvis. And trust me, you will be tempted to bear down because the threat of severe constipation after the surgery is almost guaranteed.
Is that because of the anesthesia?
Partially, yes. General anesthesia essentially turns off your autonomic nervous system, which halts the normal peristalsis, the, wave-like muscle contractions of your digestive tract.
Right.
But the bigger culprit is actually the pain medication. If you are prescribed narcotics like Percocet or Dilaudid, those opioids bind to receptors in your gut and practically paralyze your bowel.
Oh, man. So your digestive tract is asleep, you are taking medications that paralyze it further, and if you sit on the toilet and try to force a bowel movement by pushing, you run the very real risk of mechanically blowing out your surgical repair.
Yes, it happens far more often than you would think.
So how do we engineer our way out of that? The consensus across the board seems to be aggressive hydration and lubrication. Like, you need to be drinking 1.5 to 2 liters of water daily.
Bare minimum, yeah.
But more importantly, you shouldn't try to tough it out with just fiber. The guidelines recommend having over-the-counter stool softeners like Colis or an osmotic laxative like milk of magnesia already stocked in your recovery capsule before surgery.
Definitely. And if we look closely at a scoping review of urogynecology evidence we pulled for this deep dive, there is a fascinating, unconventional strategy to wake the bowel up faster. They suggest chewing gum.
Okay, I have to push back on this one too. Chewing peppermint gum. That sounds like an old wives' tale you'd read on a sketchy internet forum.
I know, it really does.
Like, how does chewing gum do anything for a bowel that is paralyzed by heavy narcotics?
It sounds like a placebo, but it actually taps into a deeply wired neurological pathway called the cephalic phase of digestion.
The cephalic phase.
Right. When you chew gum, the mechanical act of chewing, combined with the flavor, tricks your brain into believing a large meal is currently being consumed.
Oh, wow. I never thought about that.
Yeah, so the brain immediately sends vagus nerve signals down to the stomach and the intestines, ordering them to wake up, start secreting digestive enzymes, and begin contracting to make room for the incoming food. It is a completely harmless, drug-free way to jumpstart your digestive motility.
That is wild. Your brain is basically sending an emergency wake-up call to the gut, all because of a stick of gum.
Exactly.
Okay, so chew some gum, drink your water, and use your footstool. But if the goal of this entire blueprint is zero strain, the logical conclusion in my head is that you should just lie perfectly still on your couch for 6 consecutive weeks.
I see how you'd get there, but no.
Yeah. Looking at the ERAS protocols in our sources, doing nothing is heavily cautioned against.
It is highly dangerous. ERAS stands for Enhanced Recovery After Surgery. Historically, the medical community did exactly what you just suggested. They prescribed total, strict bed rest. But we quickly realized that total immobilization is the enemy of recovery.
Because if you just lie there, you start developing secondary complications.
Exactly. When you lie perfectly still, blood pools in the deep veins of your calves, creating a massive risk for deep vein thrombosis or blood clots.
Oh, that's scary.
And furthermore, when you're flat on your back, gravity isn't pulling your diaphragm down. your lungs can't fully expand, meaning fluids can accumulate in the small air sacs, which can rapidly lead to post-operative pneumonia.
So we have a paradox. You can't strain, but you can't freeze.
Right.
The guidelines from the Royal Women's Hospital seem to strike a balance. They recommend spending at least 30 minutes lying down flat every single day to take the gravitational weight of your organs off your pelvic floor.
Ah,
But on the flip side, you should not sit or lie in bed for more than 2 hours at a time while you're awake.
you have to keep the machine running on idle, essentially.
So what does idle look like when it comes to exercise? The guidelines are remarkably consistent here. Daily walking on flat, level ground is your absolute best friend. Climbing stairs in your house is perfectly fine. You just have to take them slowly.
Walking provides cardiovascular circulation without jarring the pelvis, and that blood flow carries oxygen and vital nutrients directly to the surgical site, accelerating the tissue fusion we discussed earlier.
But let's say you are a highly active listener. Maybe your normal routine involves a Scaremaster, or you're eager to get back to your morning jog.
This is where patients often get into trouble, and we have to be uncompromising. The sources are unanimous. Absolutely no inclined stairmasters, no jogging, no horseback riding, no cycling, and no high-impact aerobics for a minimum of 6 to 12 weeks.
If walking is good, why is a light jog so catastrophic?
It really comes back to the physics of gravity and impact. When you walk, one foot is always on the ground, displacing your weight smoothly. When you jog, there is a moment where both feet are in the air.
Oh, I see where this is going.
Every single time your foot strikes the pavement, it sends a shockwave up through your skeleton. Simultaneously, gravity pulls the entire weight of your internal organs violently downward. That creates a repetitive, bouncing downward force on tissues that are desperately trying to knit themselves together.
It's the sledgehammer against the submarine hull again.
Precisely. Now, I will caveat this by noting that a recent medical article analyzing post-prolapse activity suggested that a slightly more liberalized approach to fitness is emerging.
Okay, so some leeway.
Maybe, but they stress this heavily depends on your baseline pre-surgery fitness. If you were doing intense cross-training before surgery, your tissues might be dense and conditioned enough to handle a slightly faster return to activity than someone who was sedentary. But honestly, that is a highly specific timeline you can only negotiate with your personal surgeon.
So until they clear you, do not go rogue. Stick to the flat ground walking.
Absolutely.
Now, there is one specific type of exercise I noticed a glaring contradiction about in our sources. Kegels, pelvic floor exercises.
Whoa.
Some packets say you should start doing them immediately to regain strength, while others explicitly command you to wait.
It is arguably the most confusing area of post-operative care for patients. If we synthesize the underlying logic of the guidance, the overarching rule is this. You absolutely must wait until your urinary catheter is removed, and you are avoiding urine completely normally on your own before you even attempt a Kegel.
And when you are finally cleared to start, the Alberta Health Guide makes a point that it isn't just about doing them. It's about executing them with perfect form.
Form is everything.
They say you have to squeeze the internal muscles as if you were trying to stop the flow of urine. But the crucial instruction is that your belly, your legs, and your buttocks should not move at all while you do it. Why is that isolation so critical?
Because if your belly is moving during a Kegel, it almost always means you are bearing down. You're performing that Valsalva maneuver we talked about on the toilet. A Kegel is designed to pull the pelvic floor up and inward. But if you tense your abdominal cylinder at the same time, you are pushing pressure down.
The two forces cancel each other out.
Or worse, the downward pressure wins and you are actively straining your own sutures under the guise of doing your physical therapy.
Thanks.
Yeah. You want a clean, isolated internal squeeze, held for 3 to 10 seconds, followed by a complete relaxation. And I must emphasize the relaxation part. If your pelvic floor muscles are spasming or already too tight from surgical trauma, or if attempting a Kegel causes you sharp pain, you must stop immediately. Pushing through pain will only trigger more inflammation.
Which brings us to the final piece of the recovery puzzle. We need to talk about the local environment around the surgical incisions.
Right, the physical maintenance of the site itself.
Yes. The first major rule here is water safety. The discharge packets universally state that you can usually take a shower 24 to 48 hours after you are discharged. But you absolutely cannot take a bath, get in a hot tub, or go swimming for at least 1 to 2 weeks, and often much longer.
Beyond the obvious risk of introducing bacterial infection from sitting in standing water, there is a very specific structural danger, particularly for patients who underwent a procedure called urethral bulking.
That is the procedure where the surgeon injects a thick gel directly into the walls of the urethra to puff it up, right? So it seals more tightly and stops the incontinence.
Exactly. That medical gel needs time to integrate with your cellular tissue. If you submerge your body in a hot bath or a hot tub too soon, the sustained high temperature can actually soften and disperse the bulking agent before it sets. You can literally melt away the results of the surgery.
That is terrifying.
No.
Okay, showers only. Do not melt the repair.
Okay.
But what if you are dealing with intense swelling and pain in the perineal area? The APOPS guide provided some incredibly creative DIY medical hacks for this that frankly blew my mind.
They are deeply practical solutions born from patient experience.
To ice the area without dealing with bulky, uncomfortable plastic ice packs, they suggest taking a preemie-sized baby diaper, opening up the absorbent layers on one end, filling the inside with crushed ice, and then using the diaper's own sticky tabs to seal it shut. Because of the way a diaper is shaped, it creates a perfectly soft, contoured ice pack.
It's so smart.
Alternatively, you can take a heavy-duty sanitary pad, soak it in water, and simply freeze it.
It is wonderfully inventive. Just remember the clinical protocol for cold therapy: 10 minutes on, 10 minutes off. Leaving ice against delicate genital tissue for too long can constrict blood vessels to the point of causing localized tissue damage.
Okay, good to know. We also have to define a phrase that is printed in bold red letters on almost every single discharge packet: pelvic rest.
Yes, pelvic rest is an absolute non-negotiable medical directive. It means nothing, absolutely nothing, goes into the vagina for a minimum of 6 weeks.
Nothing at all.
No tampons, no douches, and zero sexual intercourse. The vaginal incisions are incredibly delicate. Introducing any foreign object can introduce pathogenic bacteria or mechanically tear the stitches right out of the tissue.
You'll also want to seriously rethink your wardrobe for those first few weeks, because depending on how your bladder responds to the trauma of surgery, there is a very real chance you will be sent home with a Foley catheter.
Yes, that's very common.
The Brigham and Women's Guidelines mention this specifically. If you have a tube exiting your urethra attached to a plastic drainage bag strapped to your calf, wearing your favorite pair of tight sweatpants is going to be a nightmare.
Comfort and physical accessibility are paramount here. Flowing, loose dresses, oversized nightgowns, or a simple wrap robe are infinitely more practical. They easily accommodate the catheter tubing, they prevent thick waistbands from chafing against any lower abdominal incisions, and they make those frequent, highly choreographed trips to the bathroom much easier to manage.
So if we step back and pull all of this together, preparing your home for a pelvic surgery recovery really isn't about rushing out to a medical supply store and buying expensive high-tech equipment.
Not at all.
It is entirely about engineering a low-strain environment where you simply do not have to reach, lift, or strain. It's about setting up that metal cake pan of essentials right next to your spot on the couch. It's remembering to throw a plastic garbage bag on your car seat. It's keeping a footstool next to your toilet and, hey, maybe chewing a piece of peppermint gum to wake up your digestive system.
It is about proactively controlling all the external variables you can control so that your body has the energy and the safety to do the complex, invisible work of healing the variables you can't.
So, as we wrap up this deep dive into the literature, what is the biggest takeaway we should leave the listener with?
I think studying these protocols forces us to look at our daily physical lives through a completely different lens. Once you realize just how much invisible intra-abdominal pressure you generate, doing mundane tasks like bending over to pick up a dropped sock, pushing a vacuum cleaner across a rug, or simply sitting up straight in bed, you start to understand just how incredibly hard our core and our pelvic floor work for us every single second of the day.
They really are doing constant work.
They are the unseen shock absorbers of our entire existence.
Whoa.
So, the question I would leave you with is this. Even after your 6 weeks of recovery are up, even after your tissues have perfectly fused and you're medically cleared for all activities, how might respecting that invisible pressure change the way you consciously move through the rest of your life?
That is a profound way to look at it. Once you finally understand how much pressure the hull of the submarine takes on a daily basis, you stop taking it for granted, and you definitely stop banging on it with a sledgehammer. Thank you so much for joining us on this deep dive. Take this blueprint, arrange your cake pans and your couch pillows, and go build your ultimate recovery sanctuary. You've got this.